I'm here to share what we have done in the UK, what we didn't do in the UK, so that you can learn and you can try to improve your leverage of your own IT. Because IT is a huge investment, and trying to lever it and trying to gain the most from your investment right at the beginning will make your systems more effective in the future. So in the UK, about 25 years ago, we began to computerize, and we began to bring numbers into our systems. And today, we have a really sophisticated system. Every GP in England uses the system. Every practice does, and it's built around a quality framework. So the concept that I want to share with you initially is the concept of a modifiable criteria, a healthcare criteria that you can measure and that changes with time. So in the UK, we chose our modifiable criteria. We chose things like HbA1c, thyroid function test, BMI, smoking, blood pressure, all the sort of universal sort of numbers that you may want to choose in your system. And every month, a GP or a practice gets a report on their system on how they're caring for their practice population. The system works, but part of the reason I've come today is to share this with you, that it's possible, it's happening, but also to share with you what we didn't do and what we haven't done. And also, I'm also here to answer your questions, so if I can, I know. Good. So what we really didn't do is we didn't audit the interventions that generated the change. It's complicated why we didn't do that, but it's quite important as a physician to know what is it that I'm doing? Is it making a change or is it not making a change? So a specific example is in terms of blood pressure. If I'm looking at the blood pressure of my population, is a beta blocker working better than an ACE inhibitor in that same population at that same time? So at the moment in the UK, we don't know. And we don't know because our systems weren't designed to generate the report on the interventions. So this is why I called my topic an audit bicycle. Because not only should you be auditing your criteria on this side, which is pretty straightforward. As physicians, we know what a BMI is, we know what blood pressure is, we know thyroid function tests. These are pretty straightforward. But on the other hand, the audit bicycle is that you need to also audit your interventions. What is it that you're doing that's making a change? And your systems can do that for you if you design your systems at this stage and if you give the specification. So for example, we used Microsoft Access database. The database worked great. It is able to do this. The technology is there for you to do. You just need to learn to do that. I'm not really talking about research. I'm talking about audit. Research is placebo-controlled, double-blind clinical trial. This is audit, so that you know actually what's happening in your population, and in England we know in real time what's happening to our population. So that's my sort of presentation, pretty short. I'm here also to answer questions. I'm also here to maybe share some stories about other things we didn't do or other things we did do. With the way it's structured at the moment is that I think we're going to have a plenary session. So I'll share with you another thing that we didn't do in the UK, which seems glaringly obvious in retrospect that we should have done. We didn't look at deaths. So here we were a team of GPs 20 years ago sitting around designing computer systems. And for some reason, we didn't look at death as an outcome. If we had looked at death as an outcome, we wouldn't have had the biggest mass murderer in UK history. Or we would have picked him up a lot earlier. Because he was generating something like 10 to 6 times more deaths per year than every other GP. So that was something we didn't pick up, and maybe you'd like to look at deaths as part of your sort of audit systems, because we didn't. So for example, yesterday I was here, and it was really interesting. We had the Chime group, and there was a lot of resonance between myself and the Chime group. They were really sort of mainly IT sort of people, and so as a physician I was interested. And what they had top of their list of one of their slides was one of the most important aspects of healthcare is empathy and compassion. There it was, there, and everybody in the room agreed that empathy and compassion are key measurements for healthcare. Yet in the UK, not once have we ever tried to measure empathy or compassion. And maybe I leave it to you as a challenge in India, especially after we had such a beautiful and moving ceremony at the beginning of this meeting, where we called upon the blessings of the Almighty, the most compassionate. So really, as physicians and as workers in the healthcare industry, we need to reflect God's compassion, and currently we're not measuring that. So we have patients who are leaving the hospitals where we don't know whether we've been empathic to them. We don't know whether we've been compassionate to them. But yet, it does seem an important measure for them that we're not doing. As I'm running well at the moment, I'll share with you one of the things that we did do which was successful using IT. Because part of our problem is, how do we change the behavior of patients? It's really difficult. How do we, what is an effective intervention? And the issue we had in Rochdale at the time, and less so now luckily, is we had a huge amount of heart disease. We had the highest level of heart disease in the known world, in the Western world. And firstly, using IT, we were able to identify in our population the risk factors for those patients to have a heart attack. And now it's really, it's well known, blood pressure, cholesterol, smoking. These are sort of obvious things now that doctors know. However, at the time, we calculated out a queue using our IT systems, so that we were able in our population to be able to say to 100 people in our population, look, you're right at the front, ready and waiting to have your heart attack. If you want, you can come into the practice or you can come into our building and we can advise you how to lower your position in the queue. But we've already booked your bed on ICU for you. It's already ready and waiting. You're in the queue. It's going to happen. And that was an amazingly effective intervention. It was a very personal intervention. They realized that they were 10th or 15th in the queue in their local town, waiting to have their heart attack. It worked. So they came in and they were really interested. They wanted to know, look, how can I move myself down the queue? And sure, we have affected the incidence of coronary heart disease in Rochdale. So for example, one of the things I'm sharing with you is using a queue mentality. So for example, going back to Mrs. Leela, who had a severe asthma attack, sure, it's possible with your IT systems to generate a risk for an asthma attack. You can generate queues of people who are likely to have an asthma attack. It's possible. So what that would mean is that Mrs. Leela knew she'd be at risk of heart attack. And in the UK now, we empower our patients with preventative medicines for their asthma. So they have rescue steroids and things like that.